Let's talk about bleeding during pregnancy. We can talk about this based on the trimesters. So spontaneous abortions, ectopic pregnancies, molar pregnancies, these are seen during the first trimester. Placenta previa, we don't recognize it in a more diagnostic manner until late into the second trimester, and then placental abruption, usually during labor and delivery, or if there's an accident, a trauma, motor vehicle accident of some sort. So we're going to take each one of these and talk about them. Let me start my slideshow. So it's a little prettier for you. So spontaneous abortions, we also call these miscarriages, but the proper ICD-10 code term is spontaneous abortions. There is a video here in the top of the screen. It's very descriptive, very detailed about each one of these, plus several more different kinds if you're interested. Let's focus more on the difference between a threatened abortion and an inevitable abortion. The cervix. A threatened abortion, the cervix is closed, okay? Whereas inevitable, it's open, okay? There's no pain with a threatened abortion. A client will usually call the office and say she's bleeding, but she denies pain, and she can be a little emotional and tearful because she's concerned, okay? Versus an inevitable, there's a lot of pain. The cervix is open and she's bleeding a lot. And if she really wants this pregnancy, she's going to be very, very emotionally upset. So how do we manage and how do we diagnose? We diagnose by ultrasound. Okay, we can look at an ultrasound and we can see we're looking for the embryo or the fetus, depends how far along she is. We're going to be able to see the fetal sac, the fetal pole, and if she's far enough along, we might see a fetal heartbeat. Now, we're not going to see a fetal heartbeat in the inevitable, usually not, okay? We're also going to draw some HCG levels on these clients to assess where they are, and then we're going to monitor HCG levels over the next week or so, because if the pregnancy is not going to survive, we'll see HCG levels begin to drop. Okay. Management also includes explaining to our clients to rest. Okay, psychological support is very important for during this time. If indeed it's inevitable and she's in a lot of pain, not only we're going to have her rest and psychological support, we might have to give her some analgesic medication. But most inevitable abortions, if the tissue still is retained within, some of the tissue is retained within the uterus, we need to do surgery. We need to go in and remove that tissue. And so she's going to be a little bit more manageable, have to manage her a little bit differently because of surgery, major surgery. Okay, so what's important about both of these is HCG levels. It lets us know where the pregnancy is. HCG levels, as the pregnancy is progressing, will double every other day. Okay, so if HCG levels begin to drop off, then we know that the pregnancy is not going to survive. Okay. So you can watch this video. Ectopic pregnancies, they're in the wrong place. Just like an ectopic heartbeat, the stimulus for the conduction is coming from a different place. So ectopic pregnancy means that the pregnancy, the egg was fertilized and it began to grow in the tube, and it did not make its way down into the uterus. And that could be from some fallopian scarring from infections or previous surgeries. We don't always know. So it has to be aborted either medically or surgically because it's not going to survive and it causes internal bleeding. Okay, so what are some of the clinical signs and symptoms? Your client's going to call the office or she's going to show up in the emergency room with severe pain, either on the right side or the left side. It depends where the pregnancy is. And she's at risk for rupture if she hasn't already ruptured with a lot of internal bleeding. So this is very serious. Usually if they show up late at night, we have to go to surgery to remove it. So the first thing we want to do is provide, of course, psychological support, collect some information from her, do an ultrasound, and then obtain an HCG level. Also type and cross or type and screen blood type. We want to know what blood type she is in case we need to give ROCAM. And then we could go to surgery. It's recommended that women with ectopic pregnancies wait at least 6 months prior to getting pregnant again, preferably a year, so that tube in that area can have time to heal. Molar pregnancies, I know this is very pathophysiology and is a little more complicated. So we're just going to talk about molar pregnancy, not about partial molar. So a molar pregnancy means that during fertilization, the egg did not have adequate maternal DNA material. So it's not a true pregnancy. And certainly there's no fetus, no zygote. And so what happens is those trophoblastic cells will exponentially grow, and it's called trophoblastic disease. It's not a true pregnancy. We don't see any embryo, and it is precancerous. So let's think about a clinical scenario so we can learn to differentiate what is going on with our client. Is she experiencing a molar pregnancy, or is it hyperemesis gravidarum? Or maybe it's pelvic inflammatory disease. Missing a Y there. So pain, are we going to see pain with these? Usually with hyperemesis gravidarum, we're really not going to see pelvic pain. Okay, so we're going to put an X there. Whoops, I guess I can't put an X there. So we're not going to see pain. She's not going to be complaining about pain, but she's going to be complaining about nausea and vomiting. There's going to be pain with a molar pregnancy, and there's going to be pain with an infection in the pelvis. Nausea and vomiting is found in a molar pregnancy, and it's found, of course, with hyperemesis. It also might be found in pelvic inflammatory disease, nausea from the infection. Ultrasound, what's it going to show? With a molar pregnancy, it's going to show a large uterus and high levels of HCG. Hyperemesis gravidarum is just going to verify that there is a pregnancy. Okay, HCG levels should be normal for the gestational age. Pelvic inflammatory disease is going to show inflammation, and of course, there's not going to be any HCG. So how do we manage molar pregnancy? We have to do a DNC, dilatation and curettage. Go in there and remove all of the little vesicle material, the trophoblastic tissue, as much as we can. And then we're going to monitor her and draw HCG levels every couple weeks for a while, so we know all those trophoblastic cells are obliterated. And then we're going to also ask her not to become pregnant for at least a year because we want to monitor her for cancer. Okay, hyperemesis, and then prescriptions. Hopefully, we're going to give her some birth control of some sort once she heals up, and maybe some pain medication. Hyperemesis gravidarum, we're going to manage it by giving her some fluids because she's dehydrated, and we're going to give her some antiemetic medications and send her home. And send her home with some antiemetics And there's a lot of, we can give her Zofran, we can give her Phenergan, we can give her Compazine rectal suppository, we can give her Reglan. There's a lot that we can do. Pelvic inflammatory disease management, and you don't have to know about this yet, but we're going to be talking about it in week 9. So pelvic inflammatory disease, managing it, we're going to give her IV. It depends how severe it is. IV antibiotics, a combination, and we might keep her for 24 hours, and then we're going to send her home with 2 separate oral antibiotics. And we're going to do a lot of client teaching with pelvic inflammatory disease. Okay. So what else causes bleeding in pregnancy? Okay, placenta previa. Early in pregnancy, if it's after the 12th week, we can identify the placenta. Okay, it's really not mature before the 12th week. And usually we look at location. Okay? So usually by the 20th week, we can see the location of the placenta. Where is it located? Is it low lying? Is it covering the internal os of the cervix, of the endocervix? Where is it? If it's low lying, it's called a placenta previa. Okay. In these clients, we have to manage them a little differently. They're going to feel a little bit of pressure. Okay. And then the placenta abruption, we're going to have a sudden, usually it's a sudden onset. Okay, so let's, I don't know if I can move my stuff around. I can't. So let's go back. So labor induction, we are not going to be able to do any kind of labor induction for either one of these. So for our placenta previa, which is on the left, there's not going to be any pain. Okay. There might be some vaginal bleeding. And like I said, she's going to have a lot of pelvic pressure, a heaviness in her lower pelvis. We're trying to prevent hemorrhage. So fetal surveillance is very important with the placenta previa. We might have her come back every couple weeks for an ultrasound to monitor that previa. How severe it is depends on the management of it. And then we're going to instruct our client to monitor her own bleeding. Is she bleeding? Maybe she needs to rest. I actually have met people out and about. In particular, one client, I was at Home Depot, and she was in line. I'm sorry, she was actually the register. She was doing the checkout, and she was pregnant. I said, "Oh, when are you due?" And she said, "Oh, I got a long way to go." I said, "Well, how far?" She looked like she was like 34 weeks, but she was only 24 weeks. And it's because she had a previa. So sometimes with a previa, you might see the fundus height be a little higher because the placenta is low, and it doesn't allow the baby to be lower in the uterus. Okay. So she said she did have a lot of pelvic lower abdominal pressure. But she didn't feel bad. She said she wasn't bleeding, so she was able to maintain that pregnancy as long as possible. Whereas an abruption, which is the other picture on the right, abruptions actually can begin early and just be a very small area. So if there is a small area of abruption, there's a huge risk that it's going to increase. So we definitely need to monitor, come in every day, not every day, every week to see how the placenta and the fetus are doing. We can do a non-stress test, we can do a BPP and look at all those things and just get a good image of that area of the placenta. But for this class, we're talking more of urgent. Okay, a sudden abruption. Okay, abrupt, believe, means quickly. That placenta will all of a sudden just pull away. And in this case, it could be just from labor, or it could be from a trauma, or sometimes cocaine use can cause this. The mortality in the fetal rate is high if she's not in-house, if she's not in labor, and she's out in the environment. If she has an abruption, the mortality rate is very high. It requires an emergent C-section. Okay, she's going to have a lot of pain, acute onset of pain. Her abdomen is going to be very firm, rigid, and she's hemorrhaging. Okay, so if you can imagine, when the placenta pulls away from the uterus, you've got bleeding from the maternal vessels as well as backflow from the placenta, which puts the fetus at risk. So can you imagine what you would see in this picture? What, other than the mother's symptoms, what would you see on the monitor if you had an abrupted placenta during labor? You think about that. If there's a lot of bleeding going on and a backflow possibly from the placenta, what might you see? Yeah, you're going to see decelerations, late decelerations. If she starts to contract and she's in labor, you're going to see decelerations, and they're going to be prolonged. Okay. So these are the 3 areas, or the 5 areas of bleeding during pregnancy: the spontaneous abortions, the threatened, which we can potentially save, but the inevitable, a lot of pain, a lot of bleeding. And both of these, we're going to monitor the HCG levels. Ectopic pregnancy, severe pain. You're going to see an ectopic pregnancy via ultrasound. And sometimes if she comes to the office or the ER, she's having a lot of pain, chances are it's rupturing. Okay. Molar pregnancy, nausea and vomiting, not a true pregnancy, precancerous, high HCG levels. Placenta previa, placenta is implanted in the wrong area, and it's covering the os. C-section, the only way we can deliver this baby. And then placental abruption, a lot of pain, mortality rate is high, and we have to do a C-section as well. Thank you, everybody. I hope you do really well on your second exam.